Hello, my name is Karen Tavares. My topic is Transcatheter Mitral repairing patient with high failure. Definition. The heart has four valves that cause blood to flow in the right direction. In some cases, one or more of the valves do not open or close properly. This can cause the flow of blood through your heart to your body to be interrupted.
Prognosis in patients with heart failure and secondary mitral regurgitation is poor, although surgical mitral valve repair and replacement have not been shown to reduce hospitalizations or death. Transcatheter mitral valve repair may improve clinical outcomes. In this multi-center randomized controlled open-label trial, 614 patients with heart failure and moderate to severe or severe secondary mitral regurgitation who remain symptomatic despite maximal medical therapy were randomized to transcatheter mitral valve repair plus medical therapy or to medical therapy alone. The primary efficacy endpoint was all hospitalizations for heart failure within 24 months. The primary safety endpoint was freedom from device-related complications at 12 months. A key pre-specified secondary endpoint was all-cause mortality within 24 months. The annualized rate of all hospitalizations for heart failure within 24 months was significantly lower in the device group than in the control group. At 12 months of follow-up, 96.6% of patients in the intervention group were free of device-related complications, exceeding a pre-specified threshold. All-cause mortality within 24 months was lower in the device group than in the control group. The authors conclude that among patients with heart failure and moderate to severe or severe secondary mitral regurgitation who remain symptomatic despite maximal medical therapy, transcatheter mitral valve repair may improve clinical outcomes. Full trial results are available at nejm.org.
Okay. Application in nursing. Channel the peripheral veins, lie and administer serum therapy and necessary medication. Monitor and watch vital signs. Prepare and evaluate the material to carry out the technique. We perform venous and arterial hemostasis. Monitor the appearance of complications.
There are two things you can do with a mitral valve that doesn't work. You can repair it or you can replace it. When we repair the valve, we have a variety of different surgical techniques and also several different ways to get to the heart.
When we're trying to decide what approach we're going to be using for a given patient, we basically look at everything to do with the patient. The patient's other medical problems, their general state of fitness, and then the actual anatomy of the valve is very important as well.
Traditional heart surgery involves making an incision right down the middle, through the sternum. And the incision is as long as your sternum or breastbone is.
As a surgeon, our goal is always to use the least invasive approach while maintaining safety.
One approach is to do what we call a conventional minimal invasive mitral valve repair through a 3 to 4 inch long incision in the upper part of the chest when a part of the sternum or breastbone needs to be divided in order to get to the mitral valve and to repair it.
More and more people ask the question, can you get to my heart without going through my sternum, without cracking my chest? And for most people with mitral valve issues, the answer is yes, we can. The approach used involves going through the right side of the chest. So there's no incision in the middle. We go between the ribs, and we can get to the mitral valve through that incision, and we can see everything we need to do to perform an excellent repair.
And lastly, the least invasive option of all includes the robotically assisted mitral valve repairs, which are performed through incisions that are very small. The longest incisions is actually only 2 centimeters in length. And the operation is performed with specialized robotic surgical system.
Generally, people who have had their approaches through the right chest rather than having their sternum split will require a bit less time in the hospital. They'll usually have less postoperative pain, and they can go back to their normal activities a lot sooner. Experience matters in surgery for the same reason it matters in anything else. The more you do something, the better you get at it. Not only are the surgeons more experienced, but the whole operating room team and also the nurses in both the intensive care unit and on the regular floors, everybody's very experienced in dealing with patients who've had these operations.
We perform more than 1,000 mitral valve operations per year.
Pros and cons. Pros. Allows sufficient laminar flow and closure of the cardiac apex by means of paths avoiding bleeding and complications. Cons. Bleeding, blood clots, valvular dysfunction in replacement valve, and heart rate problems, infection, and stroke. Issue occurred in Ecuador. In Ecuador, the impact of cardiovascular disease is quite significant. It is estimated that around 14% of the Ecuadorian population live with some heart disease. Of this, it is estimated that more than 190,000 have heart failure.
Of all the valves in the heart that break, the mitral valve is the one that we can actually repair most of the time. So what happens when a mitral valve breaks? Usually the problem is it begins to leak. We term a leaking mitral valve regurgitation. The cause of the leak or regurgitation is most often mitral valve prolapse, and I'm sure you've heard that term, mitral valve prolapse. And maybe you've thought, what does that mean? I'll tell you what it means. When we have mitral valve prolapse, it means that the valve becomes floppy. And these two leaflets, the anterior leaflet or flap and the posterior leaflet, no longer meet in the middle because one of the valves is floppy or prolapses. Mitral valve prolapse occurs because one of these cords becomes too long or breaks. So imagine this. This cord right here snaps, just suddenly snaps. That means that a portion of the valve right in here is no longer held down. It becomes too floppy. Just like if you have a parachute and say one of the struts on the parachute breaks, the canopy, which is like these flaps, the canopy no longer holds air. In this case, it's blood leaking backward. But good news, we can fix that. And I'm sure you can think immediately of one easy way to fix it. Yes, we make a new cord. If that cord is broken, we can take in the operating room a piece of Gore-Tex and just make a new one. Alternatively, we can actually cut out a small piece of the valve, cut out a little triangular piece or a pie-shaped piece, just like that. And now we've removed the part of the valve that was prolapsing or unsupported. We then sew the leaflet together, and you have a new working valve again. The final step in all of these repairs is that we put a ring around the valve. The ring is termed an annuloplasty, and you could think of that as a belt. It just goes around the valve, and it pushes in, helping to push those leaflets together so that you get a nice tight seal. And there you have it, a mitral valve that's been repaired and now works.
In conclusion, transcatheter mitral valve repair result in a lower rate of hospitalization for heart failure and lower all-cause mortality within 24 months of follow-up and medical therapy alone.
When
patients have leaky mitral valves, very early on in their course, they're not symptomatic and it's not leaking very badly. But then as the disease progresses, there's more leakage, and at some point in there, patients will start getting symptomatic. And then as the disease continues to progress without treatment, then the heart will start to change. It will start to dilate and enlarge. They are at risk for developing heart failure.
So everybody with a mitral valve problem is considered a candidate for minimally invasive surgery. And we try to do virtually all of those through that approach, but not everybody's a good candidate.
Patients want to be somewhere that does a fair number of mitral valve surgeries per year. There's fairly good evidence that the quality of the operation and the outcomes are related to volume, for mitral valve surgery particularly.
Thanks for your attention.